Welcome to the Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
And we are back. The pharmacists are in. I'm here. I'm Ajit Johal with John Papastergio. John.
Back for another episode. Excited to be here. I think we're touching on all things pharmacy, right?
Totally. And I think the best way to start today is tell us about, so I was on LinkedIn the other day and you got your PhD, Dr. John Papastergio.
Oh, yeah.
That seems to be quite a story.
Thanks. Yeah, that was an experience. And actually it goes back. It's not something I decided to do overnight. It was the story of how this all came about. It's quite interesting. But, I completed the PhD in Europe, in the Netherlands. My supervisor, a guy named Bart, a real interesting character, a real trailblazer in the area of pharmacy practice out in Europe, in the Netherlands. And, he approached me. We were on an advisory board and he said, you've got this depth of publications. You should really consider taking it a step further. And, we started going down that path. It was an interesting path. So long story short, finished the thesis, got that done. And I did that about almost a year ago. And I had to defend in person, right?
Yeah.
Yeah. And you couldn't do that virtually. So you had to get down there. It's very ceremonial in Europe. So we went down for the defense and, they get opponents, professors from all over Europe. They're there. And my thesis was in the area of pharmacogenomics and point of care testing.
Okay.
Right?
Yeah.
So,
yeah. We'll talk about that.
Yeah. We're going to think a little bit about that, but it was, really my area of research interest over the last few years. So we get into this room. It's a massive, old auditorium. You know how these European universities are, and they parade in these professors and the registrars and looks like Gandalf with this big suit.
You shall not.
Yeah. And he's got a staff and everything else. And so they pretty much tell you, you've got 10 minutes. You give a summary, and they've all read the thesis anyways, a summary of your work, and then they grill you for an hour. So we're going through this process, and, Europe is not as advanced in pharmacy practice. And this is a medical school, not a pharmacy school. So a few of the opponents are physicians. And I knew a couple of the guys and they were going to be, they're going to be realistic, but they were going to be too hard. And, but then some, you don't know what approach they're going to take towards your work. And family docs, I think, in Europe are very hesitant to see pharmacists expand their scope. So we were worried about that, like how the physician professors that were opponents would react to the work. And I think, so we're going through and it's going real smooth. So I know I'm pretty much good, but then we get to the last guy, and the last guy is a physician, and he starts by saying, my father was a physician who ran a pharmacy. You're a pharmacist who thinks you're a physician. That's oh shoot, right? No. So he had my thesis and he had everything underlined. He was going page 5 and always build it up to something, right? And then, then I'm just, this Gandalf comes in with the staff, right? He hammers it. He goes Ora Est, which means time's done, eh? So
okay.
I was saved by the bell there at the end, but
saved by the bell.
We didn't, I talked to him after, and he was a reasonable guy. It was just, there's that turf war that we see everywhere, right?
Yeah.
And it happened here in Canada, but probably 10, 12 years ago. It happens every time we go down new scope, and it's happening in other parts of the world. And I think globally, pharmacists are looking at places like Australia, Canada, the UK to say, hey, what have you guys done and what can we do? But long story short, in the end, I was successful. It was a great experience. I'd do it again. And yeah, I'm happy to hopefully use now these credentials to do a little bit more and help push pharmacy practice forward.
That's awesome. No, that's quite the story. I think I've heard stories of PhD thesis defense, and they're quite intense, but I can definitely see how in Europe with physicians, and you're talking your thesis on pharmacy practice, it's definitely intense.
And I don't think they get a lot of those, it's a medical school with they got teaching hospitals there. So I think there's advanced pharmacy practice for sure, but I think a frontline pharmacist is very different, right? And I think
Definitely.
that surprised them. But, you know, the work's evolved. If I look back at the early days, and we did a lot of work in point of care testing.
You definitely did.
Yeah, it was really observational. We were like, you know, it was not, you know, mind-blowing science. It was just no one was doing any of it, right? So we were really just documenting what we were doing. But as we evolved, but at the end, we were running randomized trials, which was not easy to do.
And
right?
you've also covered a lot of different disease states with your point of care testing. Like you've got pharmacogenomics, you've got diabetes, you've got chronic kidney disease. I think you've even looked at hypertension.
Yeah, dyslipidemia, all that stuff. I think, you know, when I look at, okay, where is this really practical for more wide scale adoption? I think it really is in chronic disease. You know, lipids, A1C, relatively cheap to do. We're seeing it roll out now in pharmacies. Shoppers Drug Mart's got a big kind of network of health tabs and point of care diagnostic devices. I mean, and it's starting to really, the consumers liking it, access to care, being able to, you know, discuss real world test results at the point of care, get the patient engaged, make clinical decisions very quickly. There's a lot of value to that, right?
Well, I think that's the big thing is chronic disease management is all about management. And it's all about timely follow-up and getting results, monitoring your chronic disease biomarkers, which are indicative of things like major adverse cardiovascular events, chronic kidney disease, but also interpretation and intervention.
Yeah, for sure. Well, we were in my car yesterday. We were driving to an event, and my brother called. Remember?
Yes.
My brother called. He went to his family doctor a few days ago. Went for blood work, like most guys, hasn't gone in a while, and then all of a sudden gets all these results back, and people can access them on Life Labs online now. Has no clue what anything means, so he's calling us panicking, right? Like, what's this? And we're kind of talking him through. You're not going to die. Everything's fine. But you know that happens all the time. It's the walking worry. They get these results and they don't know where to go. They may not have another appointment to see their doctor for 2 weeks, and if it's not critical, doctor's not calling you in early, right?
No, because it's a chronic disease, right? It's a longitudinal management. What I find really interesting, and even talking to my physician colleagues, it's like in-hospital testing versus community testing, right?
Oh, yeah.
And what I find is in hospital testing, you can get all that. I want these tests done, boom, labs downstairs, boom, results, boom, you're talking to someone. But the community, there's that disconnect, like what happened to your brother. But point of care testing can bring that back.
And it's becoming so good, so accurate, so reliable. Quality assurance is there, is that, you know, this area has evolved dramatically. When I started my work, it was handheld devices. Technology was good, but it was there really just to kind of, you know,
the
use as a guide.
Device, was that the cardio check?
You remember that one?
I do.
So that used light photometry. So that thing was all over the place, right? You had to be careful with that.
I remember it came with a CD-ROM.
That was one. But then we had the Bayer A1C now at that time. That's still around, the A1C now. But the problem was, there was a few problems. You needed different devices for all the different disease states. The other thing was there was no connectivity. So you had these, so you get, this guy's A1C is 7.8. Like, you write it down and it's gone. There was no ability for us to collect data, act on that, you know, have a patient record, and, you know, flash forward to today, and we've got these lab accurate tabletop devices, things like the Afinion. We've got now the ID Now, which is a NAT PCR. You can do PCR in your pharmacy.
It's the gold standard.
There's this wonderful tech, and now it's all kind of coming into one place, and we see it with the health tab, where it's aggregating all this data, anonymous, from all over the country. And we've been really able to use it as a lobbying tool as well, because it gives us, you know, a picture of what's going on in the real world. And we talk about studies all the time, and these are highly, you know, structured. Patients are followed under very, you know, tight clinical parameters, whereas in the real world, you start doing A1C screening, lipid screening, and what you find is very different than those studies. I mean, people are all over the place, and the pandemic has made it even worse. I mean, you go into Clinical Viewer, you don't see results for many of our patients because they haven't gone to their doctor in 2 years. Right?
No, and I did something similar in BC. We don't have Clinical Viewer. Our equivalent is Care Connect. And we'll have patients with, you know, it's really unfortunate, high A1Cs 2.5 years ago. It couldn't have gotten better.
No, it's not getting better. They got, you know,
it's definitely getting worse.
And no one's followed up.
And no change in therapy. So I think the big question is, we mutually agree that to sustain primary care, we need pharmacists offering point of care testing. The ideal, if someone says, okay, that's great, we agree point of care testing and pharmacists can play a big role. What is the expectation if we put ourselves through the lens of the pharmacist? What do you think you need to do as a pharmacist in terms of your education, training, but also the intervention and counseling, right?
Yeah.
You need to know these chronic diseases and you got to manage them longitudinally just as well as a primary care provider.
Absolutely. And you touched on an important point there is what do you do? What do you do with that information? And when we started again in the early days and we started putting these projects through ethics, right? The ethics board will always come back. So, okay, that's nice. So you find someone now with dyslipidemia or, a high A1C, but now that's your responsibility.
Oh,
right?
Yeah.
So you can't just pass the buck, say, okay, go see your doctor now, right?
Yeah.
I mean, that may be required depending where you are in the country, but the reality is you've identified that. Now you've got to take responsibility for that patient's care. And that was always a potential barrier, like pharmacists be willing to do that, right? And I think we're getting better at it, but a big part of it is having access to that data and being able to follow, which historically we couldn't, right?
Yeah.
So that technology is there.
The point of care testing solves that problem.
Right, absolutely, yeah.
But the other thing though is the intervention piece. You have a patient, a point of care test is abnormal. Pharmacists should be able to manage that. And I think the big miss nationally is we've seen expanded scope of pharmacy practice in immunization, in minor ailments, but the big missing piece, chronic disease management.
That's it. I think when you talk about, what's needed in this country with 6 million, patients not having family doctors, it's that part of it. It's the chronic disease management. That's where we're going to see this wave of need, right? And pharmacists.
Or sequelae, right?
Yeah.
Just mismanaged chronic disease, COPD, exacerbations, very costly for readmission.
For sure.
Diabetes leading to chronic kidney disease, to dialysis, amputations with dysglycemia, and then major adverse cardiovascular disease. Heart attack and stroke, those patients are less functional now. They need more care. So,
and the reality is, without that access to frontline physicians, they're going to come to you like it or not.
Oh yeah, it's happening.
Yeah, so you might as well be armed with the tech that you need, the information that you need to make the best clinical decisions. And it's funny because we're looking at, we have some data now, some newer data, and with a very high sample size now across the country, we're able to look at A1C control and lipid control in two cohorts of patients. Patients that are, we call them attached, so they have a family physician, and those that don't. Remember, it's all real world data.
Yeah, that's real world. Yeah.
So what do you think between the two? Do we see a difference?
I mean, I'm going to go out on a limb and say that the attached patients will be managed better.
No difference.
No difference.
No, statistically no difference. And that, that
so we
tells
can
you.
still do better.
We can still do better.
We can still do better.
And what that tells me is that, not that the physicians don't know what they're doing or they're ignoring these patients, they don't have time, right? Chronic disease management takes a lot of time, and those patients aren't going in to see them. So what they're doing is they're managing patients. I think many of them are acutely ill or whatnot, and these chronic patients are falling through the gap. So they may be initiated on, a lipid therapy or a diabetes therapy, but no one's managing it. And these diseases are chronic progressive,
Well, that's just the thing is as we know with evidence-based guidelines, there's graded interventions, right? Obviously, diet, exercise, smoking cessation is at every step. But a lot of these chronic diseases, you need stepwise pharmacotherapy. And when we look at diseases like chronic COPD, they have to be using the inhaler correctly. And there's so many new innovations and new, society guidelines that now say this is the best evidence. It's hard to keep up. So I should have actually known that it doesn't make a difference because we need to mobilize a whole new cohort of healthcare providers to focus on chronic disease management. It seems like pharmacists are the key.
That's the key, and I think the technology helps us be a little bit more proactive as opposed to so reactive, right? So you're there in your pharmacy, hey, you're here, you want to do a lipid screen, you want to do an A1C.
Yeah.
If we're able to do that, maybe we catch these things a little bit earlier, able to intervene, and we have actual data as well now that we know when pharmacists are armed with a point of care test, they intervene more frequently and their interventions are more complex. So they're more complicated as opposed to doing lifestyle counseling, this and that. They're actually changing therapy, adding therapy. That's, I think, a powerful thing as well.
I think that's extremely powerful. But what ultimately comes out of that is there's value in this, but it takes time. And pharmacy reimbursement and you know this just as well as anyone. It's been very product focused.
Oh,
right?
absolutely.
But it isn't. We need to move more cognitive focus, and this is an area for sure.
You know, I see the value in it. So I think the dollars will come. I think they already are in some parts of the country. I think now, I think pharmacists in Nova Scotia are getting reimbursed for some point of care. We're talking primarily about chronic disease, but acute care testing is a whole other thing. Things like strep, influenza, RSV. And we talk a lot about immunization for RSV. There's very little surveillance data on RSV, right?
Very, very, especially in the community.
Yeah. So we've got the ability to do that. Now, actually, I have a student working on a project right now. So patients coming in with a script for antibiotics. We're running the health tab and ID now. So she's offering them to swab them. So she's swabbing them and she's checking for influenza A, B, COVID, or RSV.
Wow.
And these are patients that are coming in with an antibiotic script. Guess what percentage of them are testing positive for a viral? One of them, you know?
Oh my goodness. Probably maybe 30%?
Higher, man. Yeah, it's approaching 60. And this is, we're not done
So they're testing positive for viral illness.
Viral, and they're presenting with an antibiotic.
Oh my goodness.
And you know, a lot of the times what happens too, and I know this happens a lot for strep, the doctors will give them the prescription and say, because most of them aren't doing point of care testing, right?
Yeah.
They're sending it off for culture.
It's a watch and wait.
That's right. So they'll say, hey, take this home. If you get worse for sore throat or whatever, if you get worse, or if we get a positive result, we'll call you and we'll tell you to take the antibiotic. What do those patients do? They go right to the pharmacy. They're not feeling well.
Yeah.
They're like, forget it. I'm just going to fill the script.
It's a classic. You know, you want to take something, especially if you waited a while to
and it's funny, even when armed with the test results, we still tell the patients so that they still will say, hey, you know, you tested positive for RSV. This is not bacterial. This macrolide's not going to do anything.
Yeah.
You want to hold it? Most will, but there's still, you know what, I'm just going to. And what do you do at that point? You know what I mean? So we're still working through that. But I think, you know, when we look at it, you know, antibiotic surveillance and resistance and everything else, there's another aspect to this. And we're armed with this type of technology, and you empower the pharmacist to do it. You're going to reduce antibiotic utilization dramatically. Yeah. Because the vast majority of these things are viral, right?
Definitely. And I think antimicrobial resistance is a global issue.
Oh, yeah, absolutely.
It's a global issue.
Oh, some parts of the world, man, many antibiotics are not totally ineffective because of the overuse, right? Yeah, we've had pretty good control in Canada. I think we're fortunate that way, but it's inevitable. We're going to get superbugs, you know? So how do you try to prevent that? I think this type of testing is great. And the way that the technology is evolving, these all look for DNA, right? Genetic material. You're going to be able to do one swab and look for a lot of different things, right?
That's the ideal. I think we were talking earlier about the swabbing for influenza, COVID, and RSV being 3 separate swabs.
It's becoming one, though.
That's awesome.
That's going to be super efficient, you know? And I think when you're talking about more wide scale adoption, you're going to need that. And, you know, the cost is actually very minimal. If you look at strep, like I'm not surprised that to do a strep test is like $4, eh? Like it's not expensive. I mean, some of the other viral tests are a little bit more expensive, but we're not talking about hundreds and hundreds of dollars here to get a test.
No. And then also there's good reimbursement for that education too.
Absolutely.
So there's a cost of test, but then the person administering it becomes the gatekeeper to the antibiotic.
For sure. Yeah. The other thing we've noted, you know, with respect to cost is I've seen this throughout all our papers. When you deal with chronic disease, A1C lipids, patients won't pay. They don't want to pay. They're not used to paying for stuff like that.
No.
But if it's acute care, strep, influenza, COVID,
that makes sense.
Then they'll pay because, you know what? It's for my kid. I want to know if I need an antibiotic. They're willing to pay.
Yeah.
I need something for work. They're willing to pay. So you know, there is an ROI with respect to a cash payment model. And it's funny, you do these talks in the US and they've got an entirely different model. I'm thinking, here we could probably get away. And we've asked patients, what would you be willing to pay? It ranges, you know, $20, $30. You go to the US and the pharmacist say, I could charge $80 for this, $90.
Oh, totally. Yeah.
Because of the way their healthcare system is.
It's so expensive. Yeah. So that's awesome, John. I think that it was cool hearing the story about your PhD, and it's great to hear how being a pioneer in this point of care space to take it all the way to that level. That's awesome. For our listeners, as healthcare professionals, I think in every field, what would you say if, they're thinking, how imminent is this point of care? And what are a couple things I can do to best prepare myself to embrace this?
Yeah, that's a great question. The technology is starting to roll out. If you look at, we've got the tech at Shoppers Drug Mart, I think probably 600-700 stores now. I hear of programs in Rexall and some of the other chains. I think the independents are probably going to adopt it a little bit more slowly because there's probably going to try to figure out the ROI. But the reality is, it's going to offer those pharmacies that have the technology a competitive advantage. People will go there. I already see it in my pharmacy. Here, are you the place that does blood work? People come in, they don't even know what they're testing for, right?
Are you the place that does blood work?
Well, we were even saying like a test is coming for HPV. We're going to be able to do that potentially on the Athenian. You know what I mean? So there's like there's a, I think the future is very positive. I think, the infrastructure is being built. The minute we get some public reimbursement, this can explode, right?
Well, I think that's the thing is I think this should be publicly reimbursed, especially for chronic disease management.
You know what the stakeholders say is they don't like to pay for things twice, right? So what they're saying is, well, the labs already do this. Why would I pay you to do this? Yeah. It's a totally different patient. And we see it. These patients are in our pharmacies. Yeah. Looking for services. You go with clinical viewer, they have nothing. So they're not going to access the service, and I think that's very, very, very different than the patient that's seeing their physician very regularly. And
well, even patients who see different physicians, specialists, go to the hospital, they're getting the same test multiple times.
Oh, for sure. All the time.
There's so much duplication, redundancy in the system. I think the value, though, is actually not, as we discussed, the actual test value. It's the follow-up. It's the intervention. It's the education.
And then look at the other costs. I mean, a lot of times we get focused on the cost of the test. But right now, you want to go get some blood work done. We're busy guys. You got to go to your physician, get a rec. Yeah. Now, go to the lab, pay for parking at the lab. Yeah. Wait there for 2 hours.
Well, in BC, you can book an appointment, but it's just an approximation. Yeah. It's probably about 40 minutes, 50 minutes off.
And then you go do that, and that's fine. And then, you could access the online portal. We could kind of interpret our results. Regular person freaking out, waiting. If they are the walking worry, they're anxious for those days. And then, God forbid, the doctor calls you about something, then you think they found something. Yeah.
Or even with your brother, right? Like even having access to the information causes panic.
Oh, panic, yeah. So it streamlines and it makes that whole process a little bit easier on the patient. And listen, it's not going to replace the conventional labs. We're not Theranos. Remember? I mean, this is something that
was there a Netflix show on that?
Yeah.
Amanda Seyfried plays.
No, Jennifer Lawrence,
but I think Amanda Seyfried.
Oh, did she play as well? Yeah. So they made multiple. So this lady, she was able to convince investors that they had this one-stop test and these were not like, this was Walmart and CVS and Walgreens that they convinced billion-dollar valuations. And I remember you're saying with peripheral blood, they could do all this diagnostic testing, including cancer and everything else. And, there was whistleblowers, scientists on the back end eventually said, guys, this is not working.
It's not, and then it becomes an ethical issue.
Yeah, of course. And they're like, so it all blew up. She ended up, I think, with an 11-year jail sentence. But it set us back in the point of care space because people always bring that up. Is this another Theranos? And then you've got, there was it wasn't a physician, but someone out of St. Mike's, the head of laboratory medicine there. I remember him during those days saying, what these guys are saying is impossible. There's no technology that allows us to do this. And I think we have to differentiate that these tests that are being done in pharmacies right now, they're not one drop of peripheral blood gives you everything. There are cartridges that do specific tests, and each of them requires a certain amount of time. So it is lab accurate tech, but it does have its limitations. You're not going to go in there and be able to do, a CBC and everything else, right? Yeah. And there are better machines now that are coming out that can do a lot more, 20, 25 biomarkers. Those machines need 100 microliters of blood. It's too hard to do in a pharmacy. You're not going to do that, right? Yeah. So right now, I think what we're going to see is 10 microliters or less. The data's all being captured. Now we're seeing glucometers kind of loop in as well, where they're connecting. So we're going to get blood sugar data in a very summarized form. So it's an exciting time, but it's going to continue to evolve. And we'll see where it lands. Hopefully the regulators in Ontario have bought in. There's been some regulatory change. I hear more is coming.
Excellent.
hopefully it goes, coast to coast.
Definitely. No, I hope so too. One last food for thought, John, is one last thing to consider is I'm really fixated on that attached versus unattached patient. Do you think with pharmacists prescribing, you're going to run another study?
Yeah, we should, and we can. We could do that very easily, actually. And I think we could probably do it in Alberta already. The stores that are running the tech, that'd be an interesting hypothesis. But we could see, hey, if the pharmacists are prescribing, what happens to those patients and the results?
Longitudinal.
And if they're better, man, that's a great paper.
That's a great paper. Well, hopefully it's something we see from you in the future. But thank you so much for your insights, John.
So it's great to be here, guys.
Pharmacists are back. The pharmacists are in. Check us out on Spotify and click the like button below.
Yeah, Apple, iTunes, everywhere.
Cheers.
Thanks, guys.